So today we'll be talking about the carcinomas of the testes. This is somehow very important topic to be discussed, especially when you're discussing about the genitourinary system. So since we have been discussing about the urogenital system for the couple of weeks, and so far we have discussed about the non-carcinomatous condition, like the inflammatory condition and the traumatic condition of the testes, plus kind of the developmental errors like the undescended testes. But today our main focus would be to know about the carcinomas of the testes, and obviously we'll be talking about the classification. But before I just jump to the classification and start discussing about the carcinoma of the testes, I would like to draw a particular diagram for you to understand a little bit about the anatomy of the testes. So far, I know you guys have been kind of familiar, but still, just to give you a brief description so that you can understand the spread of the carcinoma particularly. So if you could see in the diagram that this is the testicle, and the testicle is enclosed in the secretal sac. We all know that is a pouch of the skin which is apparently visible, and nature has actually protected the testicles in a secretal skin, right? So just above the part of the scrotum, you can see here a tubular structure, and this tubular structure is somehow very much important in the transportation of the sperms. If we particularly talk about the structure of the testes inside, you can see here that I'm making kind of the coil tubes, and these tubes are very much important, and they're called as the seminiferous tubules. And these seminiferous tubules, they're particularly, they have kind of the circular cells, and these circular cells are particularly important in the production of the sperms. So you can see here in the diagram that this is basically the testicle, you can appreciate. And if you particularly look upon the inside structure of these testes, you can find out that these are the coiled tubular structure, which are called as seminiferous tubules, right? And the main function of these tubules is particularly to transport, to produce these sperms, and these sperms are then transported via this tubular structure, which is present just at the top. You can see here, this is particularly the head of the epididymis. This is the body of the epididymis, and you can see here a long tubular structure, which is the tail of the epididymis, right? So actually, this whole of the part, which you can see in the diagram, starting from here and extending up to this part, this is called as epididymis. And this is something very important to know, because the local spread of the tumor actually involves the part of the epididymis, which is further connected to the vas deferens just above, close to the just in this spermatic cord, which is enclosed. So you should memorize this diagram, because if you actually understand the relationship of the testes to the epididymis and the vas, and obviously the seminiferous tubules and the seminal vesicle, you will understand the concept of the metastasis, particularly the local spread of the tumor. You know, the hematogenous spread of the tumor, particularly about the testicular tumor, this is not very common, and most of the time there's a lymphatic spread. And if we particularly talk about the lymphatic spread, so the spread of the testes is to the periodic lymph nodes, so it is actually involving the abdominal structure as well. But we'll be talking about the spread of the tumor, the metastasis, the dissemination in detail in the lecture later on. But we're just starting it from the classification of the testes. So if we particularly talk about the classification of the testes, you can see here that you can appreciate that there are two kinds of the tumor, particularly. One are the germ cell tumors, which are very much common, and the other entity is another important, which is particularly in the non-germ cell tumors. And if we talk about the germ cell tumors, about 90 to 95% of the testicular tumors, they are the germ cell tumors. Now, what do you mean by the germ cell tumors? Actually, these are the tumor cells which are derived from the totipotent, the germ cells, all the layers of the germ cells, pluripotent tumor cells, which are actually responsible for the production of the germ cells. But most of the time, if we talk about the testicular tumors, so almost 90 to 95% are the germ cell tumors, and rest of the 5% comprises about they're the non-germ cell tumors. Furthermore, these germ cell tumors are divided into seminomas and non-seminomas. So if we talk about the seminomas, they are more common in the germ cell tumors as compared to the non-seminomatous germ cell tumors. So the non-seminomatous germ cell tumors include like embryonal cell carcinoma, yolk sac tumor, teratoma, right? And the choriocarcinoma. And if we talk about the rest of the non-germ cell tumors, they're the interstitial tumors. They constitute about 2 to 5%. Some literature says that they are 1 to 2%, but some says that they are 2 to 5%, right? And they are composed of the lytic cell tumors. Another 3 to 7% of the classification is including the lymphomas, and other miscellaneous tumor group is about 1 to 2%. So, but the most important thing to know in case of the testicular tumors is to know about the germ cell tumors, because they're the most common entity, comprising about 90 to 95%. And we further divide these tumors into seminomas and non-seminomas. So seminomas are more common as compared to the non-seminomas, which are the embryonal cell carcinoma, yolk sac tumor, teratoma, choriocarcinoma, and these are the non-germ cell tumors. Other are the interstitial tumors, like they're not derived from the germ cells, and they're actually deriving from the interstitial cells. And lymphoma is another category, and some kind of metastatic tumors like the secondary metastasis is constituting about 1 to 2%. So if we talk about the embryonal cell carcinoma, if we talk about the histopathology of these embryonal cell carcinomas, they are actually derived from the embryonal tissue. And the yolk sac tumor, they're yellowish in color, and the tumor marker for the yolk sac tumor is very much important, which is alpha fetoprotein. Teratoma is a kind of the tumor which is derived from all the three layers: ectoderm, endoderm, and mesoderm. And in the teratoma, you can actually find out to have different constituents. You can find, in teratoma, there can be hair, there can be cartilage, there can be nail, there can be bone, there can be soft tissue. So because it is actually derived from all the three layers, like the ectoderm, endoderm, and mesoderm. And we know that ectoderm is, giving rise to the different structures. Endoderm is giving rise to the endodermal linings. Ectoderm is making the epithelium, and mesoderm is responsible for making the soft tissues, muscles, right? So teratoma is typically a tumor which has different kind of the tissues, like the bone, nail, hair, skin, appendages, muscles, cartilages. These are also important. There's another entity which is the choriocarcinoma, and choriocarcinoma is a kind of a very aggressive, just like the embryonal cell carcinoma, it is a kind of aggressive tumor. And choriocarcinoma is a tumor marker for the choriocarcinoma is beta HCG. So the important thing for the germ cell tumor is their first one is their origin, and the second one is the kind of the tumor markers which they secrete, right? So this was about the classification. If you could see here in the diagram, you can appreciate that this is the testicle, and you can also appreciate the part of the epididymis here. And if you go deeply to the histopathological appearance, you can see that there are kind of the glandular structures and the stromal part as well. So in the seminoma, you can see large clear cells, which are, just if you focus on the central part, you can see that they're the large clear cells, and most of the time they are containing the clear fluid. So seminomas are most common as compared to the non-seminomas. So most of the tumor and our focus would be on the seminomas. If we particularly talk about the metastasis of the tumor, like the testicular tumor, one thing you should know that a tumor can spread by three ways, right? One can be a local spread, the other can be hematogenous spread, and the other can be the lymphatic spread. But the most important thing here to know is like the seminomas, they do not have a hematogenous spread, and most of the time they spread locally or through the lymphatics. So if we talk about the lymphatic drainage of the testicles, we know that they drain into the parietic lymph nodes, and if they're involving the parietic lymph nodes, obviously they would be seeding into the abdominal cavity, just surrounding the part of the abdominal aorta as well, right? So you can see here in the diagram that this is the part of the testicles, and through the different kind of the local lymph nodes, they're actually particularly draining into the para-aortic lymph nodes. And whenever we know the abdominal aorta is centrally located in the abdomen, and their dissemination to the para-aortic lymph nodes, that can actually lead to the abdominal metastasis. Sometimes, because of the lymphatic spread, they can also spread to the pulmonary system. They can also involve the lungs, and the patient can present to you with the dyspnea and shortness of breath. But most of the time, first of all, they're because the first drainage of the testes is into the para-aortic lymph nodes, so that's why the patient will have kind of the abdominal symptoms. In case of the non-seminomatous germ cell tumors, I have already told you there are embryonal cell carcinoma, yolk cell carcinoma, teratoma, choriocarcinoma. So in out of these, embryonal cell carcinoma is deriving from the embryonal structure, and they're very aggressive, they're highly aggressive, they're poorly differentiated. Yolk sac tumors, they secrete the alpha-fetoprotein. Choriocarcinomas are also again malignant, and they're highly aggressive. And the teratoma is actually comprising of all the three germ layers, like the ectoderm, endoderm, and mesoderm, and most specifically, they have the tissues derived from all these three layers, like the bone, soft tissue, hair, skin appendages, and obviously the muscle and the cartilages as well. There's another entity which is called as mixed germ cell tumor. In case of the mixed germ cell tumors, they're kind of the different kind of the cells. There can be a combination of two tumors, like there can be teratomas, or there can be embryonal cell carcinoma. Actually, these mixed germ cell tumors, they are very rare, but they are actually very aggressive when they're full blown, because they're not a kind of a part of a simple tumor, or if we particularly talk about their cytological appearance, they can be a constituent part, particularly involving the there can be embryonal cell carcinoma, or there can be a yolk sac tumor, or there can be a teratoma. Particularly mixed germ cell tumors are the tumors in which there are a combination of two or more of the tumors. And although they are very rare, but these tumors are very aggressive whenever they are there. So only the surgical option is not an option for them. You have to go for the You have to go for the radio and the chemotherapy as well. We already have discussed like the embryonal cell carcinoma itself, and the choriocarcinoma itself is a very highly aggressive tumor. And whenever these two tumors are combined, their aggression is more as compared to their isolated effect. Plus, whenever you examine them or you go for their histopathological appearances, you can appreciate the clear yellowish cells and a mixture of tumors combining with the teratoma. And we know that teratoma is a combination derived from the ectoderm, endoderm, and mesoderm, and there can be a hair, there can be skin appendage. They can be bone, there can be soft tissue, depending upon the part. So these mixed germ cell tumors, although they're not common, they're very rare, but they're very aggressive. So there's another entity which are called as the interstitial cell tumors. And interstitial cell tumors are the kind of the tumors which are derived from the lytic cell or the Sertoli cells. Lytic cells and the Sertoli cells, they're very much important because they have somehow they're like lytic cell, they're under the control of the luteinizing hormone, and in case of the effect of the luteinizing hormone, these lytic cells actually produce the testosterone, and we know that testosterone is actually a male hormone. And these Sertoli cells actually, they produce the androgens. So the thing which is very much important about the interstitial cell tumors is like those which are related to the lytic cells, and in them, their masculine features, they're more prominent. And in case of the tumors which are derived from the Sertoli cells, the feminine features are very much common. Why? Because the lytic cells they're under the control of the luteinizing hormone, and in turn they produce the testosterone. And testosterone is, we know that the male hormone and responsible for the male sexual characteristics. And androgens are somehow they're producing a kind of the female secondary sexual characteristics. So these tumors are also very rare. They're smaller in size, they're very well circumscribed, and their local invasion or their metastatic invasion is very less likely. So most of the time they're clear, well circumscribed tumors. The thing which is important about the interstitial tumors is like pre-pubertal interstitial features and post-pubertal interstitial features. Those tumors which are presenting in pre-puberty, typically the patient will present to you with a male secondary sexual characteristic. There will be there will be more of the pubic hair. There will be masculinization of the voice as well. But in case of the post-pubertal tumors or the post-pubertal interstitial features, there would be there would be feminine features more prominent as compared to the masculine features. Like there would be loss of libido, there would be gynecomastia, and there would be particularly, which is very much important, is about the female secondary sexual characteristic. They're more important. These interstitial cell tumors, they're not very common, although they're making about 2 to 3% of all the testicular tumors. And because they are well circumscribed, they're smaller in size, and there are surgical options, like you can go for a local invasion of the testes, which is the organ sparing surgery, or else you can go for the archiectomy. But usually they have a good prognosis, they have a good response. So in case of the interstitial cell tumors, you can see here in the diagram that this is a picture taken from the ultrasonographic machine, and this can actually demonstrate about different. You can see here in the diagram that this is a wall of the. If you could appreciate, this is a this is a testicular structure which is enclosed in the scrotum, and you can see there's an increase in the thickness and a mass which is present in the center. So mixed germ cell tumors, they are a part of they're a combination of the teratoma, or they're the combination of embryonal cell carcinoma or the yolk cell carcinoma, although they're rare, but their prognosis is not very good and they're very aggressive. But if we talk about the interstitial cell tumors, they're the tumors which are derived from the lytic cells or the surface cells. And we know that lytic cells, they are under the influence of the luteinizing hormone, and they're responsible for the production of the testosterone. That's why the tumor cells which are arising from the lytic cells, they are particularly producing a kind of the masculine effects as compared to the surface cells which are producing a feminine effect. And like the rest of the germ cell tumors, their presentation is usually related to the local swelling, or their clinical features are most of the time just the painless swelling and weight loss and cachexia. But in case of the interstitial cell tumors, because they're involving the hormonal effects as well, they're involving the hormonal changes as well. So the patient can present to you with a loss of libido, impotence, secondary sexual characteristics, like there can be gynecomastia, there can be increased pubic hair. So thing which is very much important to know is you have to differentiate between the prepubertal signs and the postpubertal sign. Prepubertal are mostly involving the masculine appearances, like there can be a deepening of the voice, or there can be a kind of gynecomastia is not more commonly related to the these interstitial cell tumors prepubertal, but in postpubertal they are very much common, and they're most likely, you can see, you can divide them, or you can differentiate them on the basis of their prepubertal and the postpubertal. But the good thing about these tumors, they have a good prognosis, their surgery is not very invasive. You go for the limited resection, organ sparing surgery, or you go for the archidectomy because of their relatively smaller size, because of their less aggressive behavior, and because of their well circumscribed nature. Now, particularly if we talk about the clinical features of the testicular tumor, we all know that some tumors, like all the tumors, they have some kind of a very specific signs, like the cachexia, particular emaciated look, weight loss, but most of the time these symptoms appear when the stage of the tumor is maybe a stage 4 tumor or a poorly differentiated aggressive tumor. But initially, if we particularly talk about the testicular tumors, so in case of the testicular tumor, the patient will present to you as a painless swelling, right? They can be, because when there is a painless swelling, that can develop a sensation of heaviness in a patient, and this sensation of heaviness can be a typical first presentation, and there can be swelling, and most particularly the swelling is painless. But sometime when there's a hemorrhage into the tumor, because of that hemorrhage, the patient can actually present to you with a pain, and the pain is just like the torsion of the testes, the pain is quite disproportionate and unbearable. There can be secondarily epididymoarchitis or secondarily hydrocele as well, and sometimes I told you there can be sore pain because of the hemorrhage into the tumor, or there can be kind of the acute enlargement or secondary hydrocele of the hydrocele of the testis. But these are kind of the early symptoms. But in the later stages, what happens is, like in the grade 4 tumors, which are already metastasized, like they're metastasized into the abdominal cavity, the patient will present to you with the abdominal pain and sometimes a palpable mass as well. And if the tumor has been metastasized to the pulmonary system invading the lungs, there can be shortness of breath, there can be bilateral consolidations, and there can be infiltrates as well. So some of the symptoms are just related precisely and specifically to the local invasion of the tumor, and some symptoms are related to the metastatic lesion, and some symptoms are a part of generalized carcinomatous syndrome like the cachexia or weight loss, particularly emaciated look, but that's more common in a grade 4 aggressive tumors. So you can see that if there's a lung metastasis, the patient will have chest pain or dyspnea, and the patient can present to you with a history of hemoptysis as well. And if the tumor has already seeded into the abdominal cavity through the spread to the parietic lymph nodes, so the patient can complain to you with abdominal or the lumbar pain. Now, the thing which is very much important is, like, you start from the history. In history, typically you need to ask about history of the radiation. You have to ask about any kind of the testicular malformation. You will ask about the family history, and obviously you'll be asking about contralateral testicular tumor. When you're done with the history part of the of your examination, you're going to go for the general physical examination followed by the systemic examination. And we know that every swelling is examined in a similar way. Like you start from the inspection, palpation, and you'll go for some kind of you'll look for the redness, swelling, the size of the swelling. Then you'll go for the palpation. You're gonna see the size, consistency, mobility, fixity to the skin, or if you can get above the swelling or not, which is very much important. You'll go for the in particular in the sqadia swellings, and you'll ask the patient about the cough and pulse. You'll ask about the history of the weight loss, and you, in particular in examination, you'll be you will actually palpate intratesticular solid mass. And sometimes, because of that solid mass, actually epididymis is difficult to feel when they're flattened. And in case of the testicular tumor, rectal examination is usually normal. And in case of the germ cell tumors, 5% of the patients, they can actually present to you with a gynecomastia. So you need to examine the general physical examination as well. Sometimes, if we particularly talk about the symptoms, so there can be prepubertal symptoms and there can be postpubertal symptoms. So in case of the prepubertal symptoms, the patient will actually complain about the masculine voice. Patient will complain about lot of pubic hair, secondarily sexual characteristics, they're more important. And in case of the post-pubertal, the patient will complain about impotence, patient will complain about loss of libido, and patient will complain about the gynecomastia as well. So you need to keep in mind what are the symptoms in case of the pre-pubertal age, and what are the symptoms in case of the post-pubertal age. So, particularly if we talk about the investigations, the thing which is very much important to know is, like, you have to investigate starting from the baseline investigation. Starting from, every case is actually started from a baseline investigation. So in case of the baseline investigations, you'll go for the blood CP, you'll go for the serum electrolytes, RFTs, LFTs, you'll go for the chest x-ray, and if we particularly talk about the particular investigation, then you'll go for the ultrasonography. ultrasonography and CT scan. So the ultrasonography is actually giving you about information about kind like there's a free fluid, there's a solid mass. It will also give you the dimensions of the mass, and it will tell you, it will help you differentiate or give you a distinction between the varicocele, hydrocele, or something, right? And the third most thing important thing in case of this is like CT scan. In case of the metastasis, intra-abdominal metastasis, CT scan is very much important and kind of very informative. In case of the pulmonary metastasis, you start from the chest X-ray, and you can also go for the HRCT to look for the malignant cells. And sometimes you can also go for the, sometimes if a patient presenting with a bilateral effusion and a consolidation, and you're not sure about, you can take a pleural biopsy, and you can actually confirm the type of the malignant cells there. Same, you can go for the intra-abdominal metastasis as well. And then we have some kind of the tumor markers, and they're very much important, particularly in case of the yolk sac tumor. The tumor marker is alpha-fetoprotein, and in case of the choriocarcinoma, the tumor marker is beta-HCG. So these tumor markers are also helpful when you're making a diagnosis, particularly about the investigation. So in this particular chest X-ray, first of all, let's discuss about the ultrasound. We'll be discussing about the chest X-ray. So in this ultrasound, you can see a solid mass just present inside the scrotum, and ultrasound will give you the information about consistency. It's a fluid or solid, and then chest X-ray will give you information about the consolidation and the infiltrates as well. You can also appreciate in the diagram, these are the pulmonary infiltrates, and it will tell you about the metastatic process. Now, so far, you're done with, history and examination and kind of the basic investigation, and you have made a diagnosis of the testicular tumor. The second part in, in the progression of the tumor or in your workup is to go for the staging. And staging is something very much important, and we usually do the tumor node metastasis TNM staging. And there are 4 stages of the testicular tumor: stage 1, 2, 3, and 4, right? And the stage 1 tumors, they are confined to the testes and epididymis, right? So they're kind of the early tumors, and they're just involving the testes and kind of the local invasion involving the epididymis. Stage 2, the nodal disease is present, but the nodes are just confined below the diaphragm. And in case of stage 3 tumors, there's a metastasis, nodal metastasis, and the nodal involvement is above the diaphragm. And in case of the stage 4 tumor, there's a distant metastasis, and there's a non-lymphatic metastasis disease, like, metastasis can involve the intra-abdominal or the pulmonary part as well. So always remember these 4 stages of the tumor. Why this is important: to stage the tumor, to know the prognosis, to plan the surgery, and obviously the treatment options as well. So stage 1 tumors, they're local, they're confined to the testes and epididymis. Stage 2 tumors, they are nodal. Nodal status is positive, and the nodes involved are just below the diaphragm. And in stage 3 tumors, the nodes involved are above the diaphragm. And in stage 4 tumors, there's a non-lymphatic metastatic disease, particularly to the intra-abdominal cavity, and also involving the part of the pulmonary system as well. Now, another important thing, which is very much important, is like you stage the cancer, and then you decide the treatment strategies, right? First of all, I'll be discussing about the options we have available for the testicular tumor, and then one by one we'll be discussing the stages and then their treatment. So, sqadia exploration. an orchidectomy. This is a surgical option we have available. You actually you try to give the incision over the inguinal region, and you incise the external oblique aponeurosis. You go into the inguinal canal, you open the spermatic cord, you separate the testes, and if there is a kind of the cord is actually divided and separated up to the part of the inguinal. So the upper limit for the dissection would be inguinal ring, internal inguinal ring, or the deep inguinal ring. And obviously you do then, if you're sure about the testicular tumor and the invasion, and then you go for the orchidectomy, right? You can see here in the diagram that this is a preoperative condition, but actually when you are planning the surgery, you have to prepare the patient, you have to order for all the investigations, and then most of the time this surgery is performed under the general anesthesia. So in case of the preoperative condition, you can see here in the diagram that these are the testes, which are basically necrosed and involved and invaded by the testicular cells. And you can see that particularly this is a healthy, and this is a tumor invaded testes. So if you see here in the diagram that this is right testis, right scrotal, and the contents are divided, what you do is, again, I'm going to repeat it, in scrotal exploration and orchidectomy, what you do, you just give the incision over the inguinal region. You cut the skin, you incise the fat subcutaneous tissue, you open the external oblique aponeurosis, and you enter the inguinal canal. When you are in the inguinal canal, the most important structure that would be the spermatic cord, right? So what you do is you you separate the testes from the spermatic cord, and you dissect the spermatic cord to the part of the inguinal ring, and you remove the part of the testes which is incorporated, a whole of the testes which is incorporated by the tumor cells. So you can see here that this is spermatic cord. This is a part of the testes, and you do this surgery, and the upper limit is the deep inguinal ring, and till the deep inguinal ring you just do your dissection, and you remove this part of the testes in orchidectomy. This is a very simple procedure, and obviously you also explain the prognosis, and obviously the consequences and implications of this surgery, because it can lead to impotence and infertility. So you need to counsel the patient about that. So what are you going to do after the orchidectomy? Sometimes the seminomas, they are very much responsive to the radiotherapy. So you also put the patient on radiotherapy. And sometimes you can also platinum-based chemotherapy. That is somehow also very much important strategy for the testicular tumors, particularly those tumors which are invaded. So if we talk about the stage 1 tumor, in case of the stage 1 tumors in which the tumor is actually involving the testes and epididymis, you can just go for the orchidectomy. And for the residual tumor, to be removed, you go for the radiotherapy or the chemotherapy. In case of the stage 2 tumors in which there's a nodal metastasis, stage 2 and 3, the most important thing is this, that the nodes are also very much radiosensitive. So the thing is this, that in case of 2 and 3, you can also put the patient on on a radiotherapy. And in case of the stage 4 tumor, it's a combined platinum-based chemotherapy. You can put the patient on a bleomycin, and you can combine it with the radiotherapy, which is also very much important in case of the stage 4 disease, because usually the stage 4 diseases, they are not very much suitable because they're already metastasized, they're pulmonary infiltrates, they're abdominal infiltrates, and most of the time surgery is not a kind of option for them, and you actually put them on a palliative surgery, or you put the patient on chemo and a radiotherapy. And seminomas and those testicular tumors which have a nodal metastasis, they are very much, very much likely to be responsive to the radiotherapy, right? So these are the treatment strategies we have available for the management of the testicular tumors. So I already discussed a little bit about the stages, and then the possible surgical options we have available, or the chemo and the radiotherapy. So in case of the stage 1 tumors, in which there's a local invasion and they're just confined to the testes and epididymis, you go for the sqadia.commade, you go for the platinum-based chemotherapy, or depending upon the tumor markers. So you also keep on screening the tumor markers, and you usually making a particular diagnosis and then dividing, because if there's a yolk sac tumor, we know that these embryonal carcinomas and the yolk sac tumor and the choriocarcinomas, they're very much aggressive, and even if you do the sqadia.commade, you have to put the patient on a chemotherapy and the radiotherapy, which is very much important. So in case of stage 2 to 4 tumors, like in case of 2 and 3, there's a nodal metastasis. So we know that nodes respond very nicely to the radiotherapy. So the treatment option for the 2 to 4 tumors is like combining the radiotherapy with the chemotherapy. And sometimes, if there is a metastasis to the abdominal wall and the abdominal cavity, you can also go for the retroperitoneal lymph node dissection. And in case of the interstitial tumors, the prognosis is, not very nice. So you can go for the organ sparing surgery, or you can go for, we have the options for the interstitial tumors, right? Like you can go for the organ sparing surgery. Like obviously you're not performing the sqadia.commade, and you're just minimizing, because these interstitial tumors, they are kind of local, and their spread is limited. So in case of those diseases, you can go for the limited resection of the tumor, not the whole of the sqadia.commade, which is the organ sparing surgery. And obviously, if the tumor has already locally invaded, then you go for the sqadia.commade. So this was about the particularly about the carcinomas of the testicles, which is also very much important topic. In almost 1 to 1.5% of the tumors in men, they are the testicular tumors. And we have discussed about the classification, like there can be germ cell tumors, there can be a non-germ cell tumors, and in case of the germ cell tumors, they are they're seminomas, which are more common, and then you have the non-seminomas, like the yolk sac tumor, choriocarcinoma, embryonal cell carcinoma, and teratomas as well. Another entity include the interstitial tumors. And we have also discussed about the clinical features, the presentation. The patient will present to you with a sense of heaviness, a painless lump in the testes or testicular swelling. Sometimes when there's a hemorrhage in the testicles, the patient can actually present to you with a severe pain, and you can think about a torsion of the testes. The presentation is similar to the torsion of the testes. We have also discussed about the stages, like the stage 1, 2, and 3, and 4 tumors. Stage 1 are local tumors, 2 and 3 are those which are involving the lymph nodes, and stage 4 tumors are those in which there is more advanced metastatic disease. And we decide the treatment options depending upon the stage of the tumor. Stage 1 tumors are treated mostly by surgery, like sqadia.commade, and sometimes you can also put the patient on a radiotherapy. Stage 2, 3, and 4 tumors, you give a combination therapy, like the chemotherapy and the radiotherapy, and you put the patient on a bleomycin as well. So this was about the today's topic, and thank you for watching sqadia.com. Keep watching sqadia.com.